Hi everyone, Mark Beckstead here with the third installment of Perio Perspectives. I want to thank those of you who have offered positive feedback regarding the first two videos that we've produced. Today I'd like to talk about crown lengthening for restorative purposes. Crown lengthening is indicated for natural teeth when caries or fractures or resorption occur at or underneath the gingival attachment level. Let's review for a moment the concept of the biologic width. Going way back to 1961, Gargiulo presented on the biologic width. He found that the connective tissue attachment of the periodontal attachment to the tooth measures 1 millimeter, and that is followed by the epithelial attachment of 1 millimeter and a sulcus depth of 1 millimeter. So the attachment is 2 millimeters total with a sulcus depth of 1 millimeter. We should be thinking in terms of 3 millimeters for the biologic width. The treatment for clinical crown lengthening, there are really three options. One option is gingivectomy, in which case the gingiva is removed, but that does not reposition the attachment to the tooth. Another commonly used technique is apically repositioned flaps with osseous resection. That apically repositions the bone as well as the connective tissue and epithelial attachment levels. The other option would be orthodontic extrusion, in which case the tooth is extruded, and during that extrusion, oftentimes if fibrotomies are done, the tooth can extrude, leaving the gingival margin in a more apical position. I'd like to talk a little bit about the most commonly used technique for crown lengthening, which is apically positioned flaps with osseous resection. I'd like to show a case that I recently treated. So if we look at this x-ray, there were caries on the mesial of this tooth under the existing crown. The dentist removed the old restoration, re-prepared the tooth, and found that the preparation was at the attachment level. At that point, he put on a temporary restoration and referred the case to me. I felt like this was a good case for clinical crown lengthening. The furcations are up high. The bone level on the distal is already in apical position. So really, when I look at osseous resection, I have some work to do here, and then leveling that osseous with the distal should end up with a fairly even contour. And of course, the soft tissues follow the bony contour and are also apically positioned. We usually wait 6 to 8 weeks as a minimum before the tooth is then re-prepared and an impression is taken. In the anterior part of the mouth, we might wait 3 to 6 months. Literature shows that after 3 months, the gingival margin position is stable. So in thinking about crown lengthening, that should come to your mind as you're doing preparations that extend deep into the tissues, particularly if there's bleeding present or if you can determine where the clinical attachment level is. If there's any question, usually the answer is to go ahead and do crown lengthening. Next time we'll talk about crown lengthening for aesthetic purposes and show some clinical cases as well. Thanks. Look forward to seeing you next week. Bye.